For those that don't know me, I'm Ingrid Barker and I'm Joint Chair of the two trusts, UHBW and MBT. I'm particularly delighted to welcome newly elected governors who've chosen to come and join us today. So we've got Caroline Crowe. Hello, Caroline. Phil Smith and Paul Wheeler. So next time we're here, you'll be sitting around the table with us, and really pleased to have you here. But sadly, that does mean that we will be losing some of our very much valued governors as well. So John will be saying a little bit later, and Carol sadly can't be with us today. Have I missed anybody? Libby, of course. I thought Libby was here.
She couldn't make it today.
Oh, okay. I thought I saw her out there. Mistaken identity. Sorry, Tom. Tom, of course. Tom Fruin. So it's a time of, welcomes and sad farewells, but very pleased to see our new governors with us. We do have a couple of our colleagues online, as you can see. So Anne, Lisa and, Rachel, that's you.
That's me.
And we have apologies from Roy Shubabrata. Okay, shall we also notice that we have Finance Digital Spotlight for the main part of our kind of holding to account session today. So welcome to members of that committee, non-executive and executive alike. Any declarations of interest in relation to today's agenda? No? Okay, in which case, any questions from Foundation Trust members that we've received that we need to pay attention to? Not today? Okie dokie. So we'll go on then to look at the minutes from 21st of November and the 3rd of April. For 21st of November, first of all, are there any amendments? Okay, are we content to take those as a fair record then? And the 23rd of April, any amendments? Okay, so Convene has chosen this precise moment to kick me out and asking for my password. So can you just bear with me for 1 minute? Otherwise I'll have to squint over it. Would you do me a favour and take us through the matters arising while I just get back online? Thank you.
Yes, so the first action was for the corporate governance team, which was about making sure we circulated the minutes more timely after the meeting. So we've committed to doing that. Action's closed, but please do shout if that's not working for you, governors. So if the council are happy, we'll close that. Thank you. The chair's report. So this was a request for our group chair Ingrid to include an update around the group hospital development in the report, and we've said that we'd do that going forward. Happy with that? Yes. Are you there? Do you want me to carry on?
I'm there. I'm back in. So yes, in fact, we have already the last 2 or 3 chairs' reports have had that included in them. So that's already actioned.
Do you want me to carry on?
Yeah, you might as well now.
Why not? And then, as part of the theme of the month, Alex Ness was asked to just to confirm some retention figures for our internationally educated nurses, and that was included in the governor's newsletter back in January. So happy to close that action, seeing nods. And then the final action, which is also suggested to be closed, was for an update from Sam Chapman, who's our lead on organisational development, but also vaccination, to provide the final uptake figures for COVID-19 and flu vaccinations, and that information was included in the action log. Are we happy to close that action? Fantastic. Can I hand back?
You can. Thank you very much.
Thank God for that.
Are there any other matters arising that people would want to pick up? No? Okay, thank you. So we'll just go to my group chair's report from the last board in common, which took place last week. So that's our second board in common that we held, and I know some of you were there and others may have watched it online. So thank you for your interest in that. So this is the same report that would have gone to the board. And some of you, I hope, will have picked up earlier today or maybe yesterday my video that I did after the board, which I'll be doing every time after a board meeting now. I had previously been doing them at MBT, but now that we're a group board, I'm going to obviously do them across both trusts. So,
yeah, it's good.
did you like it?
Yeah.
Good. So some of what I'll say now might be repeating some of what I put on the video, but anyway. So really important range of visits that I've done, and also Martin and Sarah as the two vice chairs. Really important to stay connected to the services and to hear the realities of what people's lives are like on the front line, if you like. So that's ongoing. Not on here because it happened since, but it was really great to go to the Full Hearted Awards event last Friday. So celebrating the achievements and the successes of a number of colleagues from around the trust. So that was good to acknowledge and highlight what they've been doing. And John, you were there. Yeah. So it was a wonderful event at the football stadium. We actually got to go on the pitch and down the tunnel and all of that, so that was quite nice. I have met with a range of partners as normal. I would highlight the new Health Watch Chief Executive. If you remember, that service was tendered not very long ago and there's a new team in place. So the new Health Watch Chief Exec and I met, and I think we'll form a really strong partnership. Maria and I have also met with a range of local authority partners. Integrated Care Partnership Board I attended and met with some other system partners as well. Integrated Care Partnership Board, two really important items on it actually. One was to do with damp and mould and the way that affects people's physical health, particularly respiratory problems. And there's been a toolkit created that all of our colleagues can use to signpost so that people can get help with that and hopefully improve their housing conditions to reduce health issues arising from it. So I thought that was quite interesting. And there was also a review of the ICS mental health strategy, which I was particularly interested, not only because my background is mental health very substantially, but also I've been doing some joint visits with the chair of Avon and Wiltshire Partnership Trust, so our mental health provider. And the most recent joint visit we did was to Callington Road. I met Ben just after it actually, to go on a walking one-to-one with his dog, which was great. But that visit just highlighted how important our partnership is, because the interplay between physical and mental health services is just enormous. So I went, for example, to one of their older people's wards. Obviously loads of physical health issues there as well. And, you know, my question is how can we work better in partnership to support that? But also some really interesting, one particular project, which is a joint effort between AWP, the ambulance service, and Brisdoc, so primary care, doing an urgent and emergency response for people in mental health crisis to actually keep them away from our doors, because A&E would almost certainly be the place they'd rock up otherwise, and a much better and more appropriate response for them as well. So that was a really interesting visit. I think I might leave it at that, because I say most of what I've put in this report was in the video, so I won't labour it. But very happy, and I'm sure Martin is as vice chair, to pick up on any points from the report that you want to explore. So over to you.
Ben?
It was just one, and I obviously want to acknowledge, that board scheduling has been chaotic. I think is the best word over this first half of the year. But it's the last report we'd obviously received as a Council of Governors from you was in January, and obviously this is only a report from April. So I was just wondering, for governors who don't have the chance to read through all the board papers and see your reports from previously, whether you care to sort of just sort of share a little bit about what you've done previously between sort of January and April. We haven't had those reports come to this meeting.
Have they not come here? No.
Well, we haven't had a meeting, so
No, because we haven't had a Council of Governors meeting.
Obviously, I think the plan going forward is that we'll align.
Yeah.
Yeah.
But so maybe we could send it back I'm not honestly sure, Ben, that off the complete top of my head I can remember enough to make that move.
Fair enough.
But I mean, broadly, it has been about service visits,
Yeah.
working with partners, both within the NHS and outside of it. So that would include politicians, university, third sector.
Yeah.
So a lot of that stuff, some national stuff, talking to other chairs across the country, for example, some big national meetings that have taken place. I mean, Maria and I were at one just at the in fact, on the very day that all the big announcements were made about NHS England being abolished and ICB, and Maria will cover that, I think, in her report. So there's been some big national stuff too. Will that do? As an off the top of my head. But very happy to have earlier reports circulated if people haven't had an opportunity to look online at them.
Looking at the schedule, I think it's planned that Council of Governors will line up more with Public Board going forward. But I think, just the nature of where it's been in the last 6 months means that they haven't lined up well, and we've...
Yeah. You did have the video from the last board but one, so that was April. So you did have the video from that, I think, and it got chopped around a bit. So I know some of you commented that it looked a bit choppy, but apparently I'd said more than I should have done in terms of the group comms, because we had a timetable for that, and I'd kind of run away with myself a little bit on it. Go on.
I was just going to say, so all governors get access to the board papers in public, which includes those reports. Very happy to team can pick up and share some of those reports directly if that's more useful. But there was only one meeting that was cancelled, and we had that conversation in terms of although all of the Council of Governors do align with the board, and we've always been clear about that for many years, about the connection between the two meetings.
Yeah, and just to clarify, so the last report we received was when we had an ad hoc development seminar where we had the reports from both Maria and Ingrid. Then on the 29th of January, the board has met 3 times since then, so we've obviously only today received 1 report, whereas there would have been 3 and forwards. But I think that is because of the scheduling.
Yeah, and it has been unusual because we had 2 boards in short order. So we had one in April, which was all about the formalities of setting up the group, really. So putting in public what you'd already seen about the benefits case and some of the other governance decisions that we needed to make to formally launch the group. So we had an extra board, so that's why they've been 3, as you say.
Maybe as one final thing, so if I understand correctly, look, based on what with papers we've got later, there is no update or report from you when we come to the members meeting, which falls in line with the schedule of board meetings. So that's looking at the what's the word? The standing agenda items for Council of Governors. So I think there will be one where we possibly might lack or skip a board report because we don't get an update from you. If I read the papers correctly.
I'm slightly confused, I'm afraid, Ben. So
of course,
would it be okay if we took this outside of the meeting, and maybe we can have a conversation, we can work out where we might... Yeah.
It may make more sense if we brought it up in the business cycle later on, because that's where I'm referring to.
Okay, let's pick it up there then. But the broad point is we need to align all of these meetings and make sure that the reporting lines happen in a timely way.
Yeah.
Yeah. Okay, great. Thank you.
And thank you. And
any other points on the report? No? Okay, in which case it is for note and information, and I'll hand over to Maria.
Okay, thank you. Hello, everyone, especially those who haven't met in person before, and welcome to our newly appointed governors. Great to be here today. And please do, I've provided a written report, but just getting the measure of what you like and what you expect. So please do give me feedback if you think there's more that can be done. And Ben, very happy to think about doing a digest for the governors between meetings, if that could be helpful, just to keep people up to speed, recognising that we're still trying to align. So actually the meeting that Ingrid mentioned, which was a national event in London at the end of April, was the day many announcements were made about the future of the NHS. So some fairly cataclysmic changes in terms of the abolition. It's called a number of different things. Abolition, merger of NHS England into the Department of Health and Social Care. The expectation of corporate cost reduction by 50% in both integrated care boards and in regional teams, and with an expectation that ICBs are to spend no more than a figure of approximately £18.76 per head of population per ICB. And there have been lots of publications. I think our local ICB is some way above that, so there's an expectation that costs are cut in line with that figure. So work is underway at the moment, and a transition team will be set up in each of the ICBs to work out how their functions get changed or moved around, stopped or deduplicated in some way. So the idea is that of the 42 current integrated care boards or partnerships across the country, that figure will go down considerably. It is very likely that BNSSG, our ICB, will cluster with Gloucester to cover a population of about 1.7 million. Which is probably a relatively small population. I think some of the other clusters are likely to be looking at a 2 million plus population, but it's a high density, high need population. So that is the proposal currently. There'll be a number of steps to go through before this gets signed off, but just to give people an early flavour of what it's likely to look like. So we will keep you posted on where that goes. Also wanted to talk a little bit about a new regime coming in, which is going to monitor UHBW, the group, and indeed all trusts, which is going to be called the Performance Assessment Framework. It's not quite a league table, but it will start putting people's performances into categories, tiers 1 to 5, and depending on which tier you are in, you will get a level of support that goes with that. So, if you're performing very poorly, you can expect high intensity support. And that can come in lots of different ways. So I think most people would want to try and not need support if they can avoid it, and just be able to get on with the job. I think we're in the very fortunate position across the group, but particularly UHBW, in that our performance is relatively good. So we're not in high intensity support areas at all. So just again, letting people know about that. But leadership capacity, capability, board governance, all of those sorts of things will be part of an assessment framework as well. I'm talking to you in very broad details at the moment. These are very early stages. There's lots of headlines, not a huge amount of detail underneath it at the moment. So as detail comes in, I will absolutely share with you, but there's a lot that isn't known at the moment. I've got in my written report a number of meetings that I have attended, some of which have been about improvement and productivity. As you might imagine, the focus on people delivering their financial and performance plans is very high on the new NHS England leadership and government agenda. Secretary of State is very clear about expectations around performance delivery, and making sure that we break even. So there's a big focus on productivity improvement. Something called NHS Impact, which is about the use of continuous improvement in making sure that people provide value, reduce waste, avoid duplication. I'm really happy to say UHBW has been doing this for some time with its patient first methodology, which is a continuous improvement methodology which allows people to be empowered to make their own improvements, to save money, to do what feels sensible and which adds value to the patient journey. So that is underway, and that's part of a sustainability agenda, sustainability in financial terms as well as environmental terms. The group launch, so they've been just mindful of Ben's reminder that there haven't been regular reports, but there have been a number of events going on, including an event that many of you were at, the partnership event a couple of months ago, which was a fantastic event. We had really good engagement, lots of people coming back. 2 questions were asked of our audience of nearly 100 people, including academic partners, voluntary sector partners, business community, and lots of other inputs right across the health and care system. But the 2 questions were hospital of the future, what does it look like, what should it do and what shouldn't it do, and then how we might use digital going forward, and had some really interesting engagement on that. Some of this also chimed with what is coming out in June. We're told end of June, the 10-year plan is going to be published. So we've heard that 3 times now, that it's a definite, it would be coming out in June. The 3 big expectations of the 10-year plan, you can probably mouth along with me as I say them, but it's the left shift from out of hospital into community and home, away from analogue and towards digital, and then from treating illness to preventing it and helping people stay well. So those shifts are what we are all trying to do. And the 10-year plan, there's been lots of engagement events. I know many of you have been at some of those as well. Ben, you were at the one I was at. During the day, in the evenings, getting the public's view of what is going to be important over the next 10 years. So the idea is to align that 10-year plan with the government's spending review and the reconfiguration of ICBs to line up to deliver this next stage plan. So all of that is in train. We took the opportunity at a number of those events also to talk about the group coming together. So UHBW, cross-city working with North Bristol Trust, around a joint clinical strategy whereby we are advocating for better outcomes for patients, for our people, for the population and for the public purse, doing things more efficiently and doing things once but better. And starting off with removing some of our duplicate services where one trust may have a worse outcome than if you went to another trust. And I'm delighted that our first, what we're calling single managed services, the first one went live on the 15th of April, cardiac services. So we now have a shared leadership team, and there will be another 8 coming together over the next 10 months. So it's taken us a long time to get the first one up and running. You start off saying we want to bring 2 services together, and then you realise there are a whole lot of other things that sit with that. The support services, the clinical support services, the diagnostic services that sit alongside that service, plus admin support. So all of that has been worked through, provided a really good template to trailblaze, and we'll now be able to adopt much more quickly going forward. Ingrid's mentioned a number of the visits that we've done in tandem. I think one more I would want to add is a really good event, which is with our partners at UE and University of Bristol. We ended up calling it Global Ambition, which sounds a slightly grandiose title, but we invited some colleagues over from Delhi to come and talk to us about what they're doing in the world of AI, digital, quite amazing avatar follow-up, robotic assisted surgery, etc. And we had a really good discussion when they came over, hosted this research and innovation event that we had a fairly wide audience. And as a result of that, we decided to set up a group which will look at some of those areas where we feel we can learn from others, impart our own clinical excellence, because Bristol in total is now the 3rd highest funded research environment in the country. As a group coming together, we are the 3rd largest group possibly the second in terms of numbers of people, 28,000 people. There's a very considerable asset to have as part of your community. And the links we have and the groundbreaking teaching, education, research and innovation is something that people across the world are asking to know more about. And actually, when we talk to our clinicians, one of the things they say most is, you know, we like being part of a centre of excellence. We like what we're doing, being known on a world stage. So actually, there's lots of opportunities to learn. We also know that many of our young people want to learn in a much more global environment. They want to be culturally aware. They want to have learning opportunities. And actually, if we look at many other countries where the regulatory environment is slightly different, they tend to innovate and adopt far more quickly than the UK. Our average time, partly because of our regulatory environment, is unbelievably, as an average, about 17 years from innovation to adoption in practice, which feels appalling. When we looked at our Indian colleagues, they were able to do it like that. They'd set up 5 hospitals in 2.5 years. So it's a completely different environment. Lots to learn. We can't do everything they do, and obviously it's a very different payment mechanism. But I think sharing practice between the two teams, including our university partners, was really very motivating for both teams. And both of us really focused on use of AI in the future, how we personalise, how we segment, how we target, how we use big data to make really good assumptions and predictive modelling for what trajectories courses of illness may take, those postcodes where we expect to see prevalence of disease and we therefore target appropriately. And this would fit in with the government agenda of neighbourhood health. So lots and lots for us to learn from that. Just one thing I forgot to say, which is about the change in the integrated care boards. Previously, they did an awful lot of functions. The idea is to move the performance management function they previously did to the regional tier, hence the performance assessment framework I talked about earlier, but to move a lot of other functions down to providers. And that might include things like safeguarding, special educational needs, infection control, workforce analytics. So they've outlined about 10 to 12 service areas that will move in time. It's got no time frame attached. In time is the terminology used, to providers. So again, that's, I suppose, a call to action for providers, for us to be ready to adopt those and to do those in a coherent way without any loss to continuity. I think I'll leave it there and ask for any questions.
It's great, thank you. There's a huge amount in there, isn't there? But I'm sure.
Oh, and I met Wes Streeting.
Yes.
Yeah, funny how I forgot that one. But actually, that was about how successful Bristol has been as a system in tackling the waiting list. So actually, we're one of the first systems to have got our 65 we wait down to 0. And that has been regarded across the country as a very significant achievement for our patients who don't have to wait as long. I would put some of that down to our being very lucky to have 2 community diagnostic centres in our patch, one at Cribbs, one out at Weston. Seeing lots of patients, being able to diagnose early to make sure people only go into hospital when they need to. And of course, we do have our forthcoming elective centre, which is due to open on behalf of the whole city and system on the Southmead site, but obviously serving UHBW and NBT patients, due to open end of July, early August.
Thank you very much, Maria. Anything people would want to explore further from that cornucopia of information? John?
I'll just make the comment that about the 17 years that obviously when we had COVID, things happened very quickly and there's a lot changed.
Yeah.
So when the need's there, it can be done quicker. So
Yeah.
Doesn't need to take 17
Well,
years.
COVID was a very different regime. It was just get on and do it.
Yeah.
Very permissive environment, and people thrived in that.
Absolutely.
Unfortunately, it cost an awful lot of money as well. But I would hate to see it swing back completely, because I think it really opened up people's ambition to do lots more things. So we're trying to work on that. I do think with a much more digitally enabled environment, we will be able to move forward more quickly in the future.
Any other thoughts? Stunned silence. There we go. Oh,
Right from the beginning, you mentioned the fact in NHS England and ICB, there's going to be a lot of changes and everything else, and maybe merging some departments and so on. And then you also said, well, there's a new organisation being developed to come in to check your performance. So they've made cuts in certain areas, but the cuts are now ordered. You've got somebody else coming in now to do the audits and check to me, they've saved money in one end to do that, what they're doing, and now they're going to get somebody else to check your performance.
Yeah, I think they're going to ask regions to do the performance management bit. So they exist already. But what they're being asked to do is to take on this performance assessment role, which previously sat with the Integrated Care Board. So they will do it once for the South West. There'll be one team. So the expectation is of the 7 ICBs there were in the South West, their performance management function will be very much reduced, and it will now sit centrally in the South West region. So it's not a new organisation, but it's a new function that's been removed from one tier and gone up. So 7 have gone into 1.
Okay, thank you.
Yeah.
okay. Any other thoughts, John?
You certainly covered a lot, and the first division that I might make to sort of try and get my head round it all is part strategic, part business as usual. And you started off, I think I heard you say that BNSSG is going to Integrated Care Board is going to be somehow mixed with the Gloucestershire Integrated Care Board?
Yeah.
So
That's the proposal.
yeah. I only know the names, I have no experience. You may have the experience. The regional health authorities used to exist,
They did.
and as an observer it almost feels like that's where we're going. Is there any way of heading it off at the pass to get there before they take us through the interim steps? Or are we nearly there at being where we were back in the 70s?
I think you're right. I think there's quite a circular feel about this. You know, people talk about old strategic health authorities and regional health authorities. I think the commissioner provider split that was talked about back then is something that's coming back now, going back only to strategic commissioners. Some people thought it was all brilliant then. We know now, in retrospect, that there were pluses and minuses. I don't know if we can head it off at the pass. I mean, Wes Streeting's published view that there are too many checkers and not enough doers. Some of us would go along with that, actually. Lots of things that need to be, submitted on templates and looked at, and what you've just sent in comes back to you and you go, yes, I know, it's my data that I've just sent you. I think trying to get some sense out of that actually is probably quite a good thing. The actual configuration and how it will work, I think, is to be determined.
Yes. And then in our governor meetings with the focus groups, I guess to some extent we have concentrated on the group formation. And coming here today, I was thinking we haven't talked much about waiting lists and all the things we used to talk about before the group arrangement came along. So to some extent, I suppose somehow, particularly when we finally become a group with the group board and the various management groups, it's going to be interesting to see how we as governors, continue to be able to ask the sort of questions we always asked, even though we're sitting at quite a heady strategic level.
Yeah. So one of the things we're doing at the moment is pulling together a integrated performance report, which is for the totality of the trusts and all the services we run. I think we've tried it at a couple of meetings, haven't we? So it comes to each board meeting. That will give you all the performance standards that we're expected to attain. And actually, I would say that under the new performance assessment framework, they're looking at reducing the number of things that you have to attain. They're more meaningful, but there are far fewer of them, which I think is probably a good thing, to concentrate on basic standards around urgent and emergency care, elective waiting list, cancer and diagnostics. So those reports are done. They're still regularly published. The thing that's different is that there's now a comparative between both trusts, so we're able to get both an overview, but also where is one performing better than the other. Where is UHBW much better than MBT? Therefore, what could MBT learn? And that's also part of, as we go through our single managed service clinical strategy development as well.
I need to grit my teeth and have another go at reading the integrated performance report.
Yeah.
But again, that's something to take out. Perhaps again a digest that could be done in between meetings. We could certainly provide that on some of the key headlines
And I
make it
presume
more digestible.
if there's a red light, do you drill down?
Oh yes, yes,
Yeah.
yes.
Yeah.
You were at the last board, I think, John, the
Yes, I was.
group board,
Yes.
and there had been one before that. So those are the two where we've had the new integrated quality and performance reports. I mean, there's still early days. I think it's fair to say we're working through how to refine those.
It tends not to have numbers.
Does John? Lots and lots and lots of numbers. We'll talk it out later.
Yeah.
Yeah. Okay. Yeah.
Oh, I would just say one thing actually.
Percentages. Yeah. I'll see what we're saying.
Something that has become very clear in the reducing all these various layers, that the role of provider boards is key. So actually, what has happened over time is that provider boards with the non-executives and their governors, that is the way of holding people to account. When plans go in once a year, they're signed off by the board. They come to governors, they're signed off by the board. That's what's submitted. So the board is expected to oversee the delivery of those plans. Some would say, why do you need all these other layers repeating that job? Actually, the Secretary of State, in his reconfiguration plans, has restated that provider boards are the main accountability for delivery services. And I think that's really helpful. That puts the status of the board back where it should be, the status of local governance.
So provider board is how for the group.
That's how we board. Yeah.
Oh, because I'm desperate trying to hang on to the statement. I mean, you use left shift.
Yeah.
I had to ask somebody the other day, what the heck does that mean? You've explained it, but it's the way that the health service introduces a new term.
Oh, absolutely. We try to make life as difficult as possible. People can't keep track of what we're saying.
Thank you very much.
Great. If there's nothing pressing on others' minds, should we move on?
Yeah.
Okay. So, theme for the month: finance and digital. And interestingly, we have Lisa on screen. The reason she's on screen, being part of the IT team, is that she's busily integrating various digital systems with about 5 screens open at the minute. So hello and shout out to Lisa. But we have here members of the committee that oversees finance and digital and estates. So over to you to take us through some headlines for what's going on.
Thanks, Ingrid. So I'll kick off if you don't mind. So for those who don't know me, most people probably do, Martin Sykes, one of the non-executive directors and chair of the committee. So we have now the Finance, Estates and Digital Committee. A few years back it was just Finance, and we did Finance and Estates, then Finance and Digital Estates. And we're shortly going to move back to Finance and Estates, I think. So it might be overall NHS, we're growing in fact. So yes, and thanks for introducing. We've got, this is a committee that's made up of executives and non-executives. We have 4 non-executives on the committee at the moment, myself, Arabelle, Roy, who can't be here today, and Anne Tutt, who's on the screen, and 3 executive members, Chief Financial Officer, Chief Digital Information Officer, and the Chief Operating Officer, Jane, who's also not here today. So we're obviously focusing mainly on finance and digital, and not quite so much on operational. So the purpose of the committee, I think a bit following on from what you said, really, the board, is obviously tasked with delivering its plan, its strategies across all these different areas, and the committee is effectively, in a bit more detail, able to sort of oversee, scrutinise, gain assurance on the particular bits of the strategies that are associated with finance, estates, and digital. So, the way we do that, it has been quite a lot to cover at every single meeting, so we tend to focus one meeting, one about every month, on a sort of major issue that's around that particular time. It tends to fall into a bit of a pattern because obviously the annual plan for the finances comes up at a certain time of year. Normally there's a bit of a fallow period at the start of the year for finances before we get to sort of quarter one, how we're doing against the plan, that sort of thing. So digital can slot in between that. So we have managed to sort of major and minor on each of the things at each month, if you like. We look at the risks and the mitigations, so the overall risk register parts that are allocated to these different parts of the organisation's delivery plan. And I suppose we look at the scoring of those, the mitigations, how we're doing on EU risks that come along. And I suppose one of the slight nuances that we also act as what's called the investment committee for the board. So we have some delegated financial authority to sort of approve business cases on behalf of the board up to a certain amount, which I've forgotten, call it £1 million. And to review bigger business cases than that, where we'd recommend that to the board, and also look after the capital programme, which is also investment in the estate and buildings, etc. So what we thought we'd do today is just a quick bit of detail from particularly estates and digital. We've got a small presentation on digital. Neil's going to talk about the annual plan bit that we had in the pack, pick out some key features, I think. So we'll probably do that next, if that's all right. Do we go next now?
Yeah, thank you. Yeah, hi everyone. There's a lot of familiar faces, so nice to see you again. So Neil Kemsley, the Chief Financial Officer for UHBW. As I hadn't seen you for a while, I thought I'd just sort of share a bit of feedback in terms of the financial year just ended, speak a bit about national context, a lot of which you'd have picked up in the media, I expect, and then traditionally, we've come at this time of year and we'll be slightly earlier to talk about the plan for the year just started. So as Martin said, I'm going to pick it up very much from through the financial lens, appreciating the paper you received is broader. I'm so happy to do my best, and if there's any questions from the broader operational and workforce detail, and I'll rattle through everything I plan to speak to rather than pause at different sections. And then I'll stop at the end of that bit and open up questions. So, the year just ended. For the third year in a row, our system, so the Bristol, North Somerset, South Gloucestershire system, and all the harder organisations within managed to end the year in a break-even financial position. And we are one of only 7 of the 42 systems around the country that are able to achieve that without what's described as deficit support. So additional allocations to systems, some of which managed to break even on the back of that support, some of which would have failed. So you'll get a sense that we are very much in the top performing systems across the country. I'll say more about that in a moment. The trust actual year-end figure was a £43,000 surplus, which was equivalent to about 20 minutes expenditure in terms of our daily run rate. As you would have heard from many years in a row now, that's the 22nd year
that the trust has achieved break even or better, and we're very proud of that financial track record. Breaking even at system and trust level has enabled a couple of things. So firstly, before the ICB came into being, the forerunning clinical commissioning groups had accumulated a deficit of 117 million. That has been written off because we've delivered on the previous 2 years' financial plans. And we also get an additional 43 million of capital and revenue as basically a reward for committing to break even and then achieving that break even. So for us, that 43 million is the equivalent of the deficit support that other systems are receiving. The difference is ours isn't repayable. We get to keep that and spend it on the priorities that we determine. Last bit I was going to say about 2024, 25, and you would see some of the detail, particularly those that attend the board during the course of the year. We did run up a deficit in the first quarter. At the worst point, that was month 3, an 8.4 million deficit, which is around 3% of our turnover. So important to keep things in proportion. We stabilised in the second quarter of the year, and we recovered to achieve break even in the final quarter. Now, I want to convey very strongly that this wasn't a magic finance rabbit pulled out of the hat. This was all about the delivery across the organisation. So in that second quarter, we went through a very painstaking process with all of the clinical divisions, asking them to commit to a control total at the end of the financial year. And without exception, all delivered on that requirement. And probably for the last time, I want to applaud Medical Division, Western Division, Specialised Services, and Estates and Facilities, all of whom ended the year balanced in terms of their aggregate budget. And in my experience, it's quite exceptional to achieve that. The last bit then, in terms of last year, this is a reference point for the year just started. We delivered 33 million in terms of our savings plan. Glass half full, that was 11 million pounds up on the year before. Glass half empty, we had a target of 41 million pounds. So there was a shortfall in terms of what we delivered in year, what we are confident was recurring in its nature. So I'm going to move to 25, 26. Again, a bit of national context. All 42 systems have now committed to a break-even plan for the year ahead. Only 7 have committed to that break-even without another tranche of deficit support. 3 of those are in the Southwest. We're one of the 3. So the Southwest is performing relatively well, but the rest of the country has relied on a share of the 2.2 to 2.5 billion that has been made available nationally in order for people to set balance plans. The savings targets range from 5.8% to 8.3%. These are much higher figures than would have been quoted nationally for many years. 7.1% is the average. So again, put that into the context of the 5.3% that we've committed to as a trust. So now that's national context. Then I'm going to talk more to the papers that were circulated in advance. So what you received was the operational plan that was approved by the board in April. I know that Rebecca Dunn previously came to the Council of Governors. I'm going to talk through how the plan was constructed. So I hope some of the detail you received will be familiar with the briefing on its construction. The highlights I'm going to go to. So I'm going to reference a few sections in the paper, but I've got no intention to go into much more detail. So the headline is the fact that we've committed to a 5% cost improvement target, which is 53 million. So I wanted to first explain why is that target so high. So there's 4 drivers of that. Every year nationally we are set a level of efficiency improvement. Normally that's 1%, that would be 10 million. It's 2% this year, so that's 20 million of the 53. We need to recover the savings shortfall from last year, that's the next 20 million. We've been long committed to an improvement trajectory as part of our system longer term financial plan. That's 10 million. And finally, there's 4 million of local cost pressures where we agreed as a exec, as a board, that the performance, safety, quality imperative was such that we needed to have a level of investment in this year's plan. Nobody is under any illusions in terms of how challenging it's going to be to deliver that 53 million, having delivered 33 million last year. The main difference between previous year's plans and this year's, and I know this will be covered in previous briefings and you would have picked up in terms of internal communications, is that we do have a workforce reduction part to our plan this year, and that we haven't relied on in previous years. And the figures that I have shared elsewhere, so there's basically 300 posts that need to come out of our substantive workforce, but we are investing in a new 175 posts associated with some of the investment I described earlier. So a net of 125, which is around 1% of our workforce, where across the country the average is between 3 and 3.5%. So that was section I was going to draw attention to, and I said this is just very high level. Section 4.4.2 describes all of the investments that we're planning to make this year. So this is revenue investments, sums to around 30 million. So this is in elective recovery, in some of the transitional investment around the group, and into those regulatory quality safety issues I mentioned earlier. Section 4.6, so this is about the capital investment. So at the time of writing that report, we were talking about a capital plan for the year ahead of 45 million. That has now increased to 103 million. So, and that is on the back of additional allocations we've received nationally for some of the estate's infrastructure and backlog maintenance. We have the issue in terms of reinforced aerated concrete in the eye hospital. That was a £20 million repair bill. Additional theatres for children and young people. Western ESTEC has another 2.5 million investment, and the new linear accelerator. So fantastic news that allocation has increased, or doubled on the back of new national funding. But an almighty challenge in terms of delivering that in the year ahead. And it's the usual NHS rules: you get the money, but you must spend it by 31st of March next year. Section 4.11 then was my closing comments. That sets out the highest risks in terms of delivering the plan. So don't be surprised that I'm going to talk about 53 million CIP again. Secondly, we have the challenge in terms of delivering on our elective recovery targets and earning the income that we've assumed in the plan, but also, so we must do that activity, but there's also still national deliberation around whether there'll be a cap on that payment or not, and how that will work. And then finally, just popping back to capital, we've highlighted that as the third main risk, because in our confined estate, we always know that it's really difficult to do major works when we don't have a decant facility. Obviously, we need to avoid operational disruption. And then you'd have heard Andy Jeans talking recently in terms of the Building Safety Act and some of the additional approvals we have to get before we can do anything on any of our more high-rise estate. So I'll stop there, Martin, Ingrid, and have
Thanks very much.
questions.
You want to take a few questions at this point, Martin, or go on?
Probably
to
makes
your-
sense, I suppose. Otherwise,
Yeah.
we'll probably
And
forget
then we
them.
got the digital
Yeah.
presentation as well, so just so people are thinking time as well. But open to questions. Ben?
Hi Neil. So given the NHS England have set an efficiency savings target of 2% for this financial year, how realistic do you think that is to achieve in practice, given the fact that the capital budget is particularly small and how crucially linked efficiency is to capital investment?
Yeah, so so based on last year's performance, so we delivered 3% last year. and then take into consideration that we are targeting some really difficult areas with the substantive workforce, the temporary bank workforce as well. Based on our current assessment of plans, we're forecasting delivering around 40 to 43 million of the 53. So we've got a big challenge, in the rest of Q1 to increase our confidence in terms of delivering that balance of a further 10 million. We've shown over the years that that the organisation will have that collective endeavour to strive for a line that has the benefits in terms of some of the additional capital I just was talking about. It's great news, and it does enable us to improve that infrastructure in the broader terms. I know that Neil, I'm going to use another example in some sense here. I'm fairly confident that Neil will talk about the outline business case we've got for digital infrastructure. And it wasn't in my numbers, but a further £30 million worth of investment to get our digital infrastructure to where it needs to be and aligned. So that will give us a better platform for some of the longer term improvements that I think you're pointing us towards.
Can I just jump in quickly? I mean, interesting question, because there's we always talk about efficiencies, don't we? But some of it's just more or less cost reduction, which of course is an efficiency when you divide cost by the number of activity that we do. But we still also go to the committee, and there's a massive national push on a sort of simple efficiency measure like that, which is how much work the NHS does divided by how many people or expenditure it's got, which is still significantly quite worse than it was pre-COVID. So every month nationally they put out this table that says, your trust is still 13%, effectively spent 13% more on staff, and you're not putting a single extra case through relatively. So it still seems, I think, and if Jane Farrell was here in operation, she would say we still have capacity, I think, to, put more through theatres, put more through outpatients, get people back up to the level of working that some of them were back then. And, there's always a bit of an argument that people were sort of working at 120% or something back then, but I think there is scope actually just for genuine workforce workflow efficiency, as well as the type of savings targets, which are a bit more harder edge at putting in.
So how do you actually get that to take place?
Well, it's time. Some of it is actually data driven, actually. So, if you look at things that we measure, trust measures routinely in terms of things like late starts in theatres, number of cases through theatres, how many outpatients go through a particular slot, per consultant, and quite difficult to change some of those things because people can be quite set in their ways. But, where people have done it before and has a sort of league table of comparison, say, well, look, your clinic, you only have like 6 people through your 3 hours, John here, who's your colleague, has 10 people through in 6 hours. Can't we sort of tweak your template a bit and get into a lot of complex discussion about, I see more complex new patients or something. But ultimately, if you can get that flow through a little bit better, and also make sure the admin around booking and everything is slick so people don't cancel at the last minute or not turn up, there's definite gains that can be had, I think.
Right, just a footnote to that, and their patient first projects. So I know, again, people have spoken here before about patient first improvement methodology. So clinic utilisation and theatre utilisation are really significant projects, and we could share the improvement that has been achieved over the last 18 months.
Mm-hmm.
I can see John's hand was up.
I suppose what's always in my mind is the difference in condition of the buildings here compared with Southmead. And when you've got a building like Southmead, you can afford not to spend money and sweat the asset as is used in the trade. We can go another year without doing such and such. I'm interested in that. Coming in under budget was lauded at the board meeting for those 4 departments, but to me it said, well, what wasn't done? Look, there was a plan to spend X pounds, you've spent X minus 10, so that means something wasn't done. And I have no doubt in my mind the complexity of trying to manage the finances of a hospital like UHB is massive, absolutely massive. But there comes a point where instead of looking at the numbers, you go, yeah, but we must do it. We must spend that money on certain aspects. Can I believe you probably would have weighed all that up, but can you share with us some of the decisions you've had to make to come in under budget?
Yeah. So I just need to be clear about the distinction between the revenue performance of the trust and the capital performance.
Yeah.
So in revenue terms, and that's why I was talking about the divisions earlier, we have to break even or better, and 4 divisions contributed that. On capital, we are required to live within the capital delegated expenditures limit, CDEL, the phrase that we use, and we endeavour to spend every penny of that for the reasons that you've outlined. And in the year just ended, we actually overspent by around £3 million because we got advice that there was going to be underspends elsewhere in the system, and we were invited, well, you could take advantage of that in UHBW. So we're required to try and land it again on the postage stamp. We actually overspent by £3 million last year. So I think we can, demonstrate that we use absolutely every penny that becomes available. And I also would say that, this recent good news in terms of, a doubling of the capital plan for this year is on the back of brilliant work from estate's operational colleagues to be primed for when national money becomes available, we can take advantage of it. Last thing I would say is that the capital allocations between the 2 trusts within the group reflect the quality of the estate. This year looks a little different in terms of the allocation because of the elective care centre being built on the Southmead site. It looks like it skews those numbers. Normally, UHBW would receive a greater share because of the condition.
Thank you.
Thank you. I'm keen that we move on unless there are other pressing points on the finance, because I know that governments take a keen interest in the digital agenda as well, and I don't want that to get squeezed out. But I think on behalf of all of us, Neil and Martin and colleagues, it's a really, really pleasing year-end result in what has been incredibly difficult context, not just for us but nationally as well. And we've got a challenging year ahead. There's no ducking that. These are big savings targets, and they, our break-even plan is predicated on some really tough assumptions. So we're not by any means complacent about this, but we're confident we can have a really good go at this again. So thank you very much indeed to Neil and to Martin for the finance element. I'm going to hand over to Neil and Arabelle, and of course Martin and Neil will have a contribution as well, I'm sure. But over to you for digital.
Thank you very much. What I've attempted...
Those of you that are on this line,
I've attempted to create a couple of slides, but we've given some handouts out which contain all of that information. It's exactly the same, so you can refer to it without having to do any yoga to observe the TV. And the final publication of the slides was done by somebody with much better eyesight than I, so apologies for some of the very small typeface, but hopefully the detail that's included will help us understand some of the things that we're trying to do. If I move us on. So this is just a basic recap to describe the fact that around a year or so ago now, we published a digital strategy for each organisation with a great deal of alignment within them, but they were separate and therefore have some differences contained within them. But the fundamental themes that are in them are around making the IT work for everybody so that it's safe to digitise, to make sure that we use our systems as best as we can, and to have as fewer systems in place as possible to remove variation and duplication. and to make sure that we are able to support the organisation's ambitions with the delivery of things like the joint clinical strategy. So they're really the main themes of what we set out to do. I thought what I'd focus on is really trying to lift the lid a little bit on digital, because I recognise that when we talk about digital maturity and digital ambition and shift to the left in terms of digital, it's difficult sometimes to connect that back to what it really means for our hospital, what it means for our clinical teams, and how we actually make those steps forward and make those changes. So I thought I'd pull out a couple of highlights from last financial year just to share with you. So the first one is, and it uses a bit of jargon, and I apologise for that, but basically the first one is to provide much better information into our organisation, in fact actually into our organisations. This means that we're able to stop printing paper reports and sending them around, but create data that's accessible using the computer with tools that enable people to solve their own questions. So how many of this, what performance was that, how many waiting over here, how did we do over there? Those tools are available to allow our clinicians and our managers and others to be able to get those answers without having to ring somebody up, wait in a queue, get a report sent to them by email or whatever. So a big step forward, lots more to do, but a really great step with a modern technology to enable us to do that. The second one is actually it's to do with a system that's in the eye hospital. So a little anecdote is that I was speaking to a project manager in digital a few months ago, who reminded me that when this project was initiated, she was pregnant, and that we delivered and went and go live, and her child is in primary school. And therefore, I think the message I'm trying to convey is that we've undertaken, I think, to deliver a whole raft of backlog programs that existed. And this was one of the ones that was highest risk, because the system that was in place was end of life and unsafe and needed to be replaced. So with a great deal of work, we've managed to replace that system and put that clinical service back into the place it needs to be. And there's a few numbers there around the fact that actually we've cut a load of paperwork out of the organisation. So just for information. And then the third thing we've done is we've really changed the whole landscape of how we communicate with all of our patients, predominantly regarding their appointments. So now for 2/3 of our patients, actually here and at MBT, so at a group level now, 2/3 of our patients are communicated to about their appointments digitally only, which is their preference. And therefore they're able to receive their appointment in much more real time, acknowledge acceptance of that, and indeed an opportunity to request a change through the same media. And we're working really hard to make that type of appointment management for our patients the thing that we strive forward. And I just wanted to let you know that we've actually, reduced the amount of appointments that are missed by patients being sent lots of confusing letters and reminders, and giving them a much simpler way of doing it. And of course, if people don't choose to use the electronic version, we do subsequently send a paper letter as traditionally we've done so. And then the last thing I wanted to say is actually, while we've been up to doing a few of those things, in order to drive forward the group agenda, we've been bringing the digital teams from the two hospitals together, including appointing a group leadership team. So now we have just one bunch of people managing both digital teams, doing things similarly in each of our organisations, so that we get much less variation and we can maximise our investment and standardise as much as possible. So what does all that mean? Well, if you forgive the amount of information available on that page, and like me, I will not be able to read that, I'll have to refer to my device. But I wanted to just describe a couple of things here. So this is a timeline of the things that have been delivered over that period, just to give you a bit of an insight of the work that goes on. But the most important thing, I think, is when you go to the first column, which is the 23-24 column, group is the things that we have done simultaneously in both hospitals. Obviously, the UHBW is with things we've done exclusively at UHBW and MBT exclusively at MBT. And as you go through the timeline of the H1, which is the first half of 24-25, H2, which is the second half of 24-25, and then our plans for 25-26, you'll see that the amount of work that's done on a group basis grows each time as more and more of the work is done on behalf of our patients rather than on behalf of an organisation. So we're managing things at a very different level. I could spend ages going through and describing many of these projects and how they've been delivered and the benefits and improvements that they have made. But I think what I'll do is I'll probably allow more time for conversation and questions. And if anybody wants to pick up any of these things or to clarify indeed anything there, because I know that some of them are use some acronyms and things which might not be completely obvious. So apologies for that, but please do pick that up with me if you want to. And then finally, if I just move us on, there we go. And finally, I just wanted to talk to what are we going to make sure that we do by the end of this year so that we can commit to some of those deliverables. And as Neil very kindly mentioned earlier, one of the things that we really need to do is we need to upgrade some of our basic IT across the hospital. We have a business case now which has been approved at the outline stage, which will enable us to do a procurement and then get final approval, but that will give us the mandate to go and get some of this stuff fixed properly, particularly in certain parts of our organisation. Like, for example, Western General Hospital suffers particularly, and St Mike's Hospital is also a place where we need to do urgent remedial upgrades on the technology. And that case will allow us to do it not just there, but across the organisation and level up everywhere. It says CMM, apologies for the acronym, but basically we are live as of yesterday with another system on the legacy list, which is our electronic prescribing system, which enables drugs to be dispensed and prescriptions to be created electronically rather than being on paper and on drug charts. And so we are now on a journey of implementation across our entire organisation in every ward, and it started yesterday, and so far nobody's queuing up to have a word with me about it. So I'm assuming that we are off to a good positive start. But I'll keep you updated on where that goes. But that will take us through over the next 3 or 4 months to conclude that rollout across there, which is also very exciting. We've been tasked to create a single digital strategy for the group. So therefore bringing things together completely and not having a strategy for each individual organisation. We'll also get that work done in this current year. So I will stop there and open up to any questions. Thank you very much.
Lovely, thank you very much, Neil. Now we are about to eat into coffee time, so I'm going to take it that you really want to have these questions, because I know you will. But so any thoughts, people?
Just on the letters to patients.
Yes.
You get a letter through, you've got to make an appointment, phone this number, you talk to and you get yeah, that's fine, I'll just put that on the letter. You don't need to send me another letter now, I've written it down, it's on the diary, but you still get a letter through. And then when you go, the week you're going, it's a couple of days beforehand, I get another letter on the door as a reminder. So even though it's going to finally happen, thankfully, but you're still getting problems like that. So that's 2 letters that I've received. After the phone call, I said, I don't need to be reminded. I've written it down. I'm not saying everybody be able to do that. It will still need a reminder, but I'm just saying I've told them. So I was wondering, and on your system, when you're actually, whoever's doing this, sending out the information, or do they have anything on the system that they can say the patient's been informed and you don't need to be reminded via email or a letter, if you can put that on the system, because that might then save money when it comes to postage and so on.
Absolutely, and of course we have saved 2/3 of our costs of postage, and there's more to do. I think the challenge we've got is that we have a system that we use for all of our clinics, and that system has parameters that are set. For example, how long before your appointment should you get a reminder, etc. And then those things are automatic. What happens, of course, is that in often cases we all do a short notice appointment to try and utilize our capacity. That will then mean it confuses the system, because it will send you an appointment letter and a reminder almost at the same time. And what we've got with this technology is the ability to become more sophisticated and to move away with that. But what we focused on initially is digitizing our communications so that people who prefer that can have a much better experience with that. But the next wave of developments will very much tackle how we do that, so that actually if you don't want a letter at all, you won't receive one, and you'll be able to request or confirm your appointment through electronically using the app or the NHS app actually. So they're the things that we'll be working on.
Okay. I can see the 2 Johns are wanting to come in. So
following on from Rob's point, when I've got a doctor's appointment, I get a little message on my phone, which is a much simpler way of doing it than sending out letters. Is that what you're talking about doing?
So that's what we're doing for most of our patients now,
Right.
which is literally hundreds of thousands of appointments. But obviously there are groups of patients that have not chosen to work that way and still opting into having paper. But we're working on the technology so that we make it more and more accessible. But we'll always have a safety net to make sure that if you don't have access to a device or you can't use your device, you will not miss out on your appointment. We'll continue to have a safety net. But we're striving to resolve the problems that were described earlier.
Okay, thanks.
John, whichever John you. I think John Rose was first, Pete. Okay. Right.
In the paper, you've mentioned network, outline business case and full business case for this year. And it was said to me recently that what's holding back the hospital is the infrastructure. And in my terms, it means you've got a narrow road with potholes in it and you're buying new cars, but you're running them on old roads. So I suppose I'm interested to know if what your plans are in terms of network stroke infrastructure, and how soon can you deliver it?
So thank you for the analogy. I made a note of that. It is a very accurate one, actually. I think of the network that we've got in the organisation as the difference between a really old town with a network of really narrow streets and a 5-lane motorway. And what this case that has been approved will give us is the ability to actually lay a 5-lane motorway across the organisation, so that all the traffic that needs to go at great speed up and down can go very quickly and in many lanes. The case is approved. We're likely to do the procurement and get the full business case to be finally approved before we sign the contract, and that's probably going to be in around August or September time.
This year?
This year.
Fantastic.
And then the implementation will be between 12 to 18 months, depending on the challenges we get with the estate, because some of it will need wiring and fibre and cables and so on putting in. But I'm optimistic that we can do most of the implementation between a year and 18 months.
It won't be a big bang, it will be sectional, presumably.
Well, it works. So you put the motorway in and then you connect the motorway to each of the towns with an A road.
Stop.
Well, it's it works. But yes, we will solve those problems once and for all with this case, and we'll start work on it this year. Thank you.
How far can you stretch an analogy there? Brilliant. John,
Yeah, with the obviously the upgrade of
Cars.
with all the upgrade in the software and the network and everything, obviously that implies that hardware on top of that is reliant on that. So does it mean we need to upgrade a lot of the hardware, the medical systems and things that go on top of the systems?
So the network infrastructure can be probably more readily described as Wi-Fi. It is the connectivity that we have that joins things together and allows access to things. And that is fundamental in order to get reliable performance. Even if you have a really modern fast system, if you're trying to connect to it through a really narrow, poor connection, you'll get a very poor experience as a user. So the most important thing from my perspective is to take that problem out of our environment. We do have some systems which are really modern and fast and will instantly come to life with that solution, but we do have some that will need to be replaced and upgraded, or indeed converged and merged with others.
But also the upgrade to, obviously we're going to be using Windows 11, I presume, for...
The Windows 11 will be rolled out and complete this year.
So that won't affect any hardware systems on top of that?
It won't. Well, Windows 11 is an upgrade of a desktop operating system. Most of our computers will readily take Windows 11 and perform well. There are some that won't, and they'll have to be replaced.
Yeah. No, I meant actually the medical systems on top of that are being controlled by computers and compatible with.
Yeah, there are
to Windows 11.
There are medical devices, particularly in diagnostics, that rely on old-fashioned computers because the manufacturers have not upgraded their solution, and we just will continue to maintain those services, but of course protect ourselves by isolating those old devices.
thank you. Last word, Ben.
Yeah. So obviously, we've heard in the broader context, the push this in the coming 10 months or so is going to be towards the single managed services, and where we're going to have either single leadership teams or staff operating across multiple trusts. I'm just wondering, is streamlining authentication and authorization high on the list for this year? I.e., are we moving towards one 365 tenant for login across both organisations?
So we're doing two things. So in the hidden away in that big list, you'll see that we are going to move to a single Office 365 tenant as a group by moving on to the national tenant. So we'll all go to an nhs.net email address, and that will also include calendar and SharePoint and Teams. And that's scheduled for this year. We're just waiting for our window of opportunity to migrate our existing data from NHS England. But that is approved, and work is now in train to achieve that. As soon as we get that window, I'll be able to publish when we'll have it moved, but we're aiming to have it complete before Christmas. And then the second thing is with the networking implementation, once we level up those issues at UHBW, we'll connect the two networks together as a group so that anybody will be able to work anywhere with one digital identity.
Brilliant.
Thank you.
Nirvana, isn't it?
You'll be able to move back to just having one email address.
Yes. Brilliant. Thank you so much. Thank you. Is there anything you want to add, Aaron?
Not particularly. I mean, I think it's easy to be impatient for all the stuff that we want to do, but I think Neil's done a very good job actually of kind of managing expectations around the infrastructure, because your point, John, is so well made. The infrastructure we have here just won't support all the digital ambitions that we have. So I think we're all as impatient as everybody else about really cracking on and moving ahead with a lot of this stuff. But until we've got the foundations right, we just can't do it and reliably deliver a service. I suppose the only other thing I would just mention, particularly because it's in the news a lot at the moment, it's around cyber and the cyber risk that we manage. And this whole infrastructure investment will give us a lot more protection around that. Plus, a lot of the projects you've already done, actually, just to raise up our level of sort of cyber security, is very welcome as well, because it's one of those things that you don't think about very much until it happens to you, and then there's all you think about. So I think it's great that we've done a lot of work around that as well.
Yeah, the cyber is at the centre of much of our prioritisation. So we take it incredibly seriously.
So again, thank you very much to all of your teams and to you for the work you're doing. I mean, this network upgrade is so fundamental, as has been said, and the two boards, well, it's UHBW that actually had to formally approve it, but both boards have been very much in support of that, because it is the stepping stone from which all the rest will follow. Otherwise, we're building on crumbling foundations, really, quite literally in some cases, I suspect. But really, really great to hear about the progress, and looking forward to Nirvana at the end of the year with my one email address. Fantastic.
Christmas.
Yeah. Great, thank you. Shall we take a 5-minute break for coffee and comfort break? Come back at past if we can. Okay, I think we're most of us back in the room again, so we'll crack on a bit. Beginning with Governor questions. So this is your opportunity to raise anything, particularly from the last board meeting, but anything really. Arabelle.
It's not from the board meeting, but I was just wondering, is there any way we can monitor? We seem to have some governors that we see very rarely, or very, very rarely. Can we monitor them, and is there any action we can take?
Yeah, we absolutely do, and yes, there is. But for the detail, governance people?
Yeah, so we can discuss it at a governor meeting, and we can potentially bring something to July's COG meeting to approve.
I think it would be worth it.
Yeah.
Thank you.
But I think there's a certain number of meetings you can't miss without having a good reason, and that's a matter of judgment at that point. But yeah, there is an expectation of regular attendance.
Okay.
Yeah. John?
We've got a meeting penciled in for the no criteria to resign.
Yes.
Be all, end all, take it all
Yeah.
apart, play with it. And the amount of time allocated to it, I can't help feeling it will not be enough.
Yeah, because it's only 45 minutes, isn't it? I think.
And
I don't know if it's
equally, there was there's yourself and Maria who have been tabled as being there, and I wondered if there was the chance that perhaps the team that does the actual discharge management, because I think what the governor's looking for is something a bit more than the words "it's complicated," and each one of the paths will need something different, I'm sure. So, we mentioned that for pathway 1, which is going home and being helped at home, that might be because Sirona have a shortage of people who can do that, or whatever. And it's that level of understanding that I think governors are looking for. So if there's anything you can do to
Yeah, absolutely. And I think when we originally talked about the meeting, it was going to be quite a wide-ranging discussion. So I agree, 45 minutes is not going to be enough.
we were all bringing our camping gear.
Make a weekend of it, why not?
So we'll extend that. I'll try and get some people who work in the the ClinOps, clinical operational team, who will be able to give some background and detail. I actually think it's really important we have this meeting now. We are being asked to submit a plan for winter while the sun's still out. By the end of June, we're expected to submit a plan for winter that shows that we're going to be able to cope. I won't go into the technical details now, but it probably means that we have to reduce no criteria to reside by about 9-10% from where it is now, and that's not going to happen without us taking quite significant action.
That's sort of 20 out of 200. That's not much at all, is it?
No, down to So it's currently about 24%.
That's big. Yeah.
So it needs to go down to about 14%. So actually, I think across all three hospitals,
Are the local authorities going to be with us in this meeting?
we can ask them.
Well, it's all like with the RCB, isn't it?
Yeah, and I think it's a bit like we keep scratching at it and picking at it a bit, but we're never getting everyone together to get a whole proper discussion and a whole answer on it. That's
The ICB need to be involved as well.
Yeah, I mean they have been holding a number of meetings. There have been lots of meetings, and I think it's not for want of goodwill, people trying hard, but for whatever reason, words like complexity. Actually, both trusts have received record level attendances in the last couple of months. And interestingly, talking to other chief execs nationally, doesn't seem to be related to weather, to enormous road traffic accidents, but many trusts have had their highest ever A&E attendances in the last few months. Really hard to explain. Not sure why.
You can't get to see your GPs.
It could be GP collective action. So people are working through what that data is at the moment. Why is this happening? Why aren't there enough alternatives? We do know in our system that there absolutely aren't enough alternatives. By every metric on community provision, we are very low. Particularly in the north of Bristol, actually, as alternatives to hospital, as well as provision of other care environments outside hospital. So we've sort of created a system that is doing exactly what it has ended up doing, not working very well.
It may be we start with looking at the numbers UHBW are aware of in-house.
Yeah.
Because they seem to be a movable feast. And there's figures that were published in the IQPR last April, which look very different to figures that might be published today. So it could be a long session.
So I think we agree. I know John's waiting to come. We'll do what we can about the time. We'll do what we can about the membership, but it's not entirely in our gift, as you'll understand.
Just a quick comment. I won't be here to join in with this. Obviously, you all know how I feel about it. But the way I see it is this. The problem is there. You look at it and you go, oh, it's complicated. Well, it's like a kid taking his GCSE maths. He looked at that and goes, oh, that's complicated. Do I answer the question or do I not? He answers the question. We don't. We go, oh, it's complicated. Let's put it over there. And I'd like just to leave you with this one thought. Just imagine that we're not talking about older people stuck in a hospital ward. Imagine that we're talking about children stuck in a hospital ward. Soon solve the problem then. That's the issue. That is the crux of it, is it that old people don't matter. And that's sadly the way the society looks at it. If that was children, there'd be an absolute outrage.
Yeah, John, you've got a real point. However, if you were to go to the children's hospital, there are children that have been there for far, far too long, and usually because of lack of mental health.
That's the ripple effect.
There are children, and is there outrage? Is my question.
Yeah. Well, the public aren't aware of that. If the public were aware of that, I'm sure there would be.
Any other? So we'll pick all of those points up, and we'll try and reshape the session that we've got to respond as best we can to. As I say, not all of it is in our gift, but we'll do what we can to respond to what you're asking. Are there any other points that people want to raise at this point?
No, I'm fine. Thank you.
All good. In which case, Ben, the inaugural unveiling of the lead governor report. So over to you.
Yes, there are only a couple minutes allocated, but I thought just to introduce the fact that I have put a little report in the papers of what I've done since you appointed me as lead governor back in November. If you read through it and you find it useful, then I would be happy to do one for every Council of Governors going forward, so you can see what I get up to. And it's an idea that I have lovingly pinched from Southwest Ambulance Service, because their lead governor has done one for many years. But and I'm happy to, well, I don't know whether there's time, but happy to take any questions if there are any. So
No, sure. And anything people want to raise with Ben from his report?
Well, Ben, we do raise things. We do and have a discussion. We do that we feel that could have been mentioned or haven't been mentioned or whatever. And that's the lead governor. We ask you. So in the reports, would you refer to those sort of during a whatever date, whatever, Rob, John, or whatever said this, and then you put your own little brief bullet point, not too much, but bullet point on it, so to speak. That's all I'm saying. Yes.
Yep. No, I would be happy to do that.
Any other thoughts?
It may be you have questions of Ben.
Happy to take questions from anyone around.
Well, I meet with Ben very regularly on the one-to-one, so we have a good dialogue on that basis, don't we, Ben?
We do. Yeah.
In fact, we had one only yesterday. So no, I'm all questioned out.
We talk regular as well, don't we?
Sorry, could I just come in? You've been on your report and all the work you're doing on behalf of governors, because I know that all of us really appreciate it. So thank you. You're working so hard.
Yeah,
I don't know how
well
to fit
said,
it all in.
Dennis.
Thank you.
Very much appreciated.
Lovely. So appreciation, Ben, and thank you. And it sounds like no other points on that. Okay, in which case we will move on. Governor and membership forward look.
Thanks, Ingrid. I'm going to take that paper. So this is the usual report that we present at Council of Governors to give you information and to summarise the governor activity since the last meeting, and to look forward at the activity that we've got coming up. So since our last meeting in November, we've held numerous governor focus group meetings, and you've had many updates presented to you on the group hospital model, the Trust's Pro Equity campaign, hearing about the results of the place assessments that you all attended, and updates on our elections campaign for 2025. You've also had opportunities to meet with the non-executive directors for your engagement sessions with them, and you've had 3 occasions where discussions have been held on no criteria to reside patients, improving the access to our hospitals, and the work of our dental hospital following a tour that we had recently. So your next session with them will be held in June. We've also had a meeting of the Nominations and Appointments Committee today, so obviously that was held just before this meeting. We wanted to let you know that there are spaces available on the Nominations and Appointments Committee membership. So watch out for an email that we'll be sending early June to ask for new members. And that's to coincide with our new cohort of governors that will be starting on the 1st of June. We also talked about extending the extensions for the terms of office for Sue Balcombe, Mark Griffiths and Roy Shapper-Brata, and they have been extended until the 31st of August, so everybody approved that at the last meeting. We've also had our governor elections, as everyone is well aware. They finished on the 17th of April, and the results were declared on the 22nd of April. So we had 15 seats up for election, and all of these seats were filled. The full details of everybody that was elected is in the report. It's detailed within the report. And we just wanted to flag that Tony Tanner stood down during that time, so we have also added an extra seat to cover Tony Tanner, and that's for South Gloucestershire. So looking forward, focus will now turn to inducting our new governors who are starting on the 1st of June to provide them with the skills and knowledge to fulfil their roles. So we have an induction day early June where we'll be welcoming everybody. Some governors have offered to be a buddy for our new governors. So just to remind everybody, if you're interested in being a buddy, please let us know, because we'd like to get that firm confirmed soon. I also wanted to remind you that we are currently running your self-assessment questionnaire, so it would be great if you could provide some feedback to us. I think the end of May is your deadline, so that would be really helpful to build into improvements for the next year.
I did have an issue with mine.
Oh, the form, yes. So the link, there was a bit of an issue. If you have any issues accessing the form, just let us know and we'll send you another link. I think you did send a new link though, didn't you? What else do I have to remind you? Rachel, there was something else, wasn't there?
NED recruitment.
NED recruitment, thank you, Ingrid. Yes, so we will be looking to, for the next round of our NED recruitment, so we'll be putting a call out early June for some volunteers to help us. And I think that's it. Are there any questions or anything that I've missed? Lots to tell you.
No. Anything anybody needs to pick up or explore? No, I think that was very clear. Thank you very much indeed. Okay, let's have a look at the trust constitution, which is for approval. I'm going to hand it over to Eric for this one.
Thank you. So as part of our development of the group, we've been looking at all of the governance documents which support how UHBW operates. So as you'll know, our constitution is that document which is broken down into several parts, including standing orders for the Board of Directors and standing orders for the Council of Governors. So we've been supported by Hill Dickinson, a law firm, as part of the development of the group, who have also supported the review of these documents, and our kind of approach has been, can we streamline these documents, can we bring them up to date, and can we also make sure that they're as consistent as possible? So actually, where we've got timelines for giving notice for meetings, etc., we've got common terminology and a common way of doing it. So we've been through that process to update. We've also clarified things like voting arrangements for the board to make sure that's as clear as possible. And there's just some basic changes as well that we've proposed. Ben has very kindly given some more detailed comments on the changes, which I'll pick up a couple, but otherwise I've got a suggestion of how we move forward. The first thing is the names of the documents are technically wrong from the version. So these are Annex 5 and 6, not 4 and 5 as per the document. So we haven't lost a document. Just to be clear, we haven't taken something out and not told you. It was just something's happened in the naming, so we'll clarify that. And then there's some other minor points which are not material, but do help with clarification. So thank you, Ben. So my suggestion is ask for approval today from the Council of Governors for the changes to both of those documents. I'll then review those other changes, circulate a summary of comments to all governors so you can see what we're proposing to change, and ask Ingrid if the Council of Governors are happy to approve that those changes to that document, so we then don't need to bring that back. So if governors are happy with that approach. Yeah. Otherwise, happy to take any questions on the changes.
Any thoughts or questions? Ben, are you content because you raised a number of points?
Yeah, so Eric and I just sort of sat down over lunch. I did, I think I went through both documents with a fine-tooth comb yesterday, so, and just sort of picked out, as Eric said, not material changes, but areas that I think either just may have just been missed or just felt like they needed some additional clarification. So they're not going to impact how board operates or anything like that. But yeah, happy to, rather than eat up the Council of Governors' time and go through each one. Yeah, I've just given Eric a paper, and so we'll just circulate what the changes, further changes will be, and we can just sign off over email. So.
But in substance, it's okay.
Yeah,
good.
And I think thinking back to February when we had Hill Dickinson come to and speak to us, and we were all in agreement around that table about how, well, if we're going to review and approve new standing orders that are in line between both boards, it would make sense to do it the same for the Council of Governors. So that's exactly the approach that I've taken. Just try to bring it further in line. So yeah.
Okay, good. Thank you. Any other points people want to raise on this? Okay. So I'm just having to scroll back through my. Goodness.
It's a bit lengthy, isn't it?
Yeah, it is a bit. There we are.
Governance. So.
Just making sure that I've got the right recommendation. So, given what Eric says, are we happy to approve the document, noting that there is a bit of tweaking to be done? Okay.
And happy for Ingrid to approve the final changes.
Given the tweaks.
The tweaks. Yeah.
Okay, great. Thank you all very much. Right. Business cycle and terms of reference for governors' meetings. I think there were a couple of points made at the start of the meeting that was said we'd come back to here. So
pick those up in a minute.
Okay.
So at a recent governor meeting, governors discussed the business planners for your focus groups, so the quality focus group and your strategy group, and also the membership and constitution group, which we agreed to amalgamate together. So this paper reflects those changes. So the membership and constitution items will be going into those focus groups. And just to remind you all, you won't be losing any time that we're dedicating to your meetings. We've also updated the terms of reference to reflect this change. So before we go to the approval, because it's pretty straightforward, Ben, did you want to come in with your points that you raised earlier?
Yeah, I think we worked it out. It was just because of the where the annual members meeting is not does not follow the same business cycle as a normal Council of Governors meeting. Just ensuring that in terms of Maria's and Ingrid's reports, we just get any that have gone to board since our previous Council of Governors meetings, where that's a standing agenda item. Yeah.
Fine.
So can pick that up, okay?
Yeah.
Great. Just on the members' meeting, I think the intention is for us to do a joint effort with MBT. So to have the two meetings concurrently, a bit like the board in common, I suppose, concurrently in the same event, because we are a group.
And just to add, so we'll still fulfil all of the duties required as a foundation trust to hold an annual members meeting, hear from governors, receive the annual accounts, etc. And the same process will happen for MBT for their annual general meeting. But given we're going to be hearing from group appointments, it makes sense just to bring those together. We're also looking at actually how can we perhaps have a wider stakeholder engagement event around that to make sure we hear from community partners and others, and actually involve a wider set of our population in that, share some of the really great work that goes on. So we're just trying to build that at the minute, and we'll share more details with governors in due course.
Lovely, thank you. So are you happy to approve that set of documents? Lovely, thank you very much. Governor's log of communications. So we do have the log here. Emily, is there anything to particularly pick out? There is a comment on here, I think, from Ben. Mark.
Oh, I added this as partly of me not realising how long ago the original comment was, which was November. But it relates to data and computers. So it was a response from Neil, which is well explained about. So there's a question from somebody, how come A doesn't speak to B and they don't have the right information about my clinical records? And Neil points out a whole series of things that have been done or are being done to facilitate that. But it doesn't necessarily mean that the person at the sharp end knows that can happen. So do the staff get additional training on how new linkages work so that they can find the x-rays or the ClinPath results or whatever it is that they can't find?
So there's always change programs and training programs that go with any new system rollout, whether they're attended by everybody that the new system is intended to target, and whether people remember that training at the point at which sometime later they have to do that thing, is another question. I guess that's what's happened in this particular case, where someone's at a point they just think they can't access it. Actually, there are a whole load of workarounds, but they can't remember them in the kind of moment where they're trying to access that information. I guess what Neil would say if he were here, we are on a convergence path.
Yeah.
And so, a lot of the things that are in our digital strategy and will be in the group digital strategy that he works on this year will be exactly to address this kind of thing, because as we come closer together and as we design these single managed services, of course, data flowing freely across the two hospital trusts and across the different sites is a key part of that.
Yeah.
So I think it's kind of covered by various things. Whether we'll get everybody all the time, I think that's always difficult, isn't it?
Well,
Just in
the answer
terms
is you
of
won't, but you
people.
have to have a process that facilitates it and brings people with it, because it's like having an EU IT system with people just go, oh, that's new, I can't do that.
Yeah. Well, there's no way of it. It doesn't work.
Yeah, exactly,
Yeah.
exactly.
Yeah.
But it's the key. But it must be very frustrating if you put these processes in place and people don't use it, or equally well if you don't really understand how they work and therefore you don't use them either.
Yeah.
What about Sirona? Do they have the same computer basics to get access to records from the NHS if they're a partner of the NHS doing work for them?
I wouldn't know.
I seen a Sirona doctor this morning. You had his laptop, but you couldn't get my records. I got my app, got it up within a couple of minutes. I showed him all my medication, my reports and stuff, but he couldn't access it.
Yeah, that's the problem, isn't it? Primary care and hospital system don't communicate. It's a massive problem, actually.
So that's
where
from
it's
November, the governor's log note about it. And so exactly the same. We've got an answer, but the answer isn't necessarily known, understood, enacted, etc.
Yeah. So Maria, I think you wanted to come in.
Yes, I did certainly to support what Arabelle's just saying, because I don't think the NHS has always been good at the change programme that accompanies rollouts of IT. They just go out and people expect people to pick it up. So a lot of time and effort has gone into floor walkers, the sitting next to Nelly type approach of showing people how they work. You'll always miss some people out who are away on leave or not around or away, so it's not 100% integrity of rollout, but we definitely do a lot more than we used to do. One of the interesting things when I was at this small meeting with Secretary of State Wes Streeting, was information governance, so why systems don't talk to one another. As you say, most of the public assume that when you go into a hospital, we can see that you've been to Sirona in the morning, GP 3 times last week. We can't, and we make you tell us the same story again and again and again. It's very frustrating, and actually it can make people quite fearful that we don't have your whole understanding and record. A commitment has been to try to consider the NHS as an entity. A lot of us think the NHS is an entity. If you have someone who comes and visits the UK, they say, there's about 600 NHSs. There are lots of different organisations, and we don't share information. So, for example, Sirona is actually a community interest company. It's not NHS, so we do have difficulty sharing that information without what we've just it's called an information sharing agreement for the NSSG. We've only just signed that, so that will take quite a long time to come out to share. Things you think are barred or obvious, we haven't got in place yet. But the idea actually is to wrap around the whole of the NHS to say, if it's NHS patient information, we should be able to see it across organisations, unless people choose to absolutely opt out because for whatever reason they do not want their information shared beyond that particular organisation or clinician. So it's coming, but we're not there yet.
So any other thoughts on the log?
Is there any likelihood of Libby's question being answered soon?
So Libby's questions are with comms at the moment for them to just review the response, and then I can pass them back to Libby and yourself because you were also named on that one.
Yeah.
So yeah.
Is that weeks?
As soon as I get comms sign off, that's all I can tell you. I sent it to Emma on Monday.
Oh, I remember, right.
Okay.
We'll chase it up, John.
Yeah, I think what John's saying is Libby was the one who raised this question, and John was put on it because her term of office is ending.
Absolutely. Yeah.
Just
I
to keep
fully
it rolling.
expect to have it back before she finishes on the 31st of May.
That would be good.
I fully expect to have them back. I've told Comms that she finishes and you'd like a response before then. So
Seems odd that it's comms on a clinical matter, but there we go. I might also say that I did walk the site with Andy Jeans,
Oh yeah.
fantastic.
and I've got to find the time to simplify what we discussed. My fault, not his. But essentially what we were looking at was the parking provision for those with mobility issues. And it's very difficult, unless you've got a blue badge, to actually single out those with mobility issues. But where some of the blue badge sites for parking are, you've got to be pretty fit to be able to get from that blue badge parking space to the hospital. So for instance, at the back end of the headquarters building, there's two parking spaces for blue badge holders. And then there's Marlborough Hill.
Yeah.
Right, and I showed him the way. Sounds like religious, doesn't it? I showed him the way how to get from Marlborough Street to the Heart Institute, which is quite a trek and a lot of steps. What I want to propose is that the car park associated with oncology and Heart Institute, you move all the blue badge parking spaces that you've got into that area, because it's your best entrance for anyone with a mobility problem. They can park a car, they can go and get they could go and get a wheelchair if we can find them. But that was one of the things that came out of it. We went to where the new wheelchairs should be and we found just one.
Right.
So hopefully Andy's looking into where are the other 52.
With the tracker, track them with the trackers.
Well, you can't do the trackers, isn't he still here? Can't do the trackers because the street has got potholes in it. And the trackers won't work without a proper infrastructure. Right.
Oh, no.
So
You're joking.
No. It sounds sensible to me. If you haven't got Wi-Fi and it's slow or whatever, you can't pick up where all of the equipment is. I think it's a great idea to do, but I don't think you can implement it just yet. So I'm hoping that it will come before you at some point as a proposal that if you put mobility impaired patients first, that they need to be within that area that I've described, and from level 5 you can get anywhere in the hospital.
Yeah.
So the front door is a terrible place.
Yeah.
You know, and this back door or front door number 2 could well be something you're doing for those that live in Blagton and have no other way of getting to a hospital appointment but by car.
Yeah.
I also feel for the ladies that are pregnant going to St Michael's, because if they're going out, I remember my wife when she was pregnant, she had to go there with a full bladder, and she had to walk all the way up St Michael's Hill.
Was that for a test?
No, for a scan.
So you need the full bladder to be in the scan?
Yeah, and obviously that was really painful. And then when she got out there, she had to wait.
All the women are nodding.
Yeah, but I sit there with legs crossed, and so I was just thinking that there's very few parking spaces out there, but perhaps they should have some that are literally reserved for
the hospital.
People that are pregnant.
I think there's about 4 by the entrance.
It's really hard.
And 2 of those are disabled, I think.
That's right.
So that's just to
So that's in there. Is
meeting with
that
Andy. It was
is
very-
that something that you've formally fed back on, John?
Well, that's what I've got to do.
Yeah. Okay. So it will appear in
It
here.
will appear.
But I mean, that kind of real life experience of it's gold dust, isn't it? Actually, because that is the experience of the people that are using the services. And
I think he could see
yeah,
that where's the machine? Where's that? And all sorts of little issues like you've left your blue badge in the car like you're supposed to do.
Mm-hmm.
And
You've got to bring it to the machine.
The machine says scan your blue badge here.
But do you realise, because there's no sign out there, when I first went to the heart hospital, when you said heart hospital, that's Bristolian, isn't it?
Yeah.
So you're sort of faced with this machine, so then naturally you got to get your blue badge. But you only get 20 minutes, right? What you're supposed to do...
Just get back to your car.
No, for your whole appointment. So then what you're supposed to do is not do anything until you've had your appointment and then scan your blue badge and then go.
Yeah.
Well, this is really practical stuff, and we're gonna take it through the log and feed back to you. But thank you, because as I say, this is gold dust. It's real life experience of what people are having to grapple with.
One of the things that we sort of said to each other was everybody should be walking the hospital.
Yeah, absolutely.
Because it's amazing if things you thought were this way are actually that way. All sorts of things.
That's why I spend so much time on visits. There is absolutely no substitute for going out to see, feel, touch, talk for yourself. There just isn't. But thank you very much, John. I think we are at any other business. Is there any?
John.
Oh, now we have got some sad farewells. And I know John has asked if he can have a word, but can I just also acknowledge Carol, who's not with us, and also David, both of whom have done an amazing 9 years. Sorry, Tom. Don't know where David came from. Sorry, David. So David, I don't know who Tom is. But Carol and Tom have served their full 9 years, which is amazing. So thank you so much.
Yes, thank you.
And Tom, thank you for all the expertise. I've only known you for the last 11 months, but I mean, I know that you've made a huge contribution, are very much respected by all of your colleagues. So I very much will miss you, and I know everybody else will too. And thank you again for everything you've contributed over the years. Greatly appreciated.
Oh, it's you as well. It's a whole new way of life.
You get your life back now. And John,
Yes.
you've served 8 years,
8
so
years.
you're far behind.
Yeah.
Yes, and it's a sad farewell to you as well.
Yeah. Thank you.
Yeah.
You've allowed me to make a statement.
Yeah, I know you wanted to make
and I
a few
really
words.
appreciate the opportunity to do that. Dear friends, my dad taught me the importance of being part of a community. I'm a Bristolian, born and bred. Bristol flows through me like my blood. I have tried all my adult life to do what he said and play a part in the community of Bristol. I've at various times been a special constable for 6 years, school governor for 5 years. I'm a licensed lay minister in the Church of England, and I'm in my 30th year of ministry. And of course, I've been a governor of this great institution for the last 8 years. And this is the one that my dad would be most proud of. Because he contracted polio when he was a little boy back in the 1930s. And it was the treatment he got here that enabled him to be able to walk and have a normal life. So this place has always been special to my dad and to our family. Being a governor here has been one of the great privileges of my life. I'm sorry if I get a bit emotional. And I'm grateful to have had a role in the development of the trust. The joining with Weston was a major achievement and part of it, and I was so proud to be able to take part in that. It's been an honour to be of service here because, like a lot of Bristolians, this hospital has played a major part in my family's history. Apart from my dad, with his polio, 3 of my grandchildren were born in St Michael's. My eldest grandchild literally had a life-saving operation when he was 2 weeks old in the Children's Hospital. He's now 20 years old and an apprentice carpenter. My father-in-law and my own father both had heart surgery here that enabled them to live longer lives. My wife is currently receiving treatment involving injections in her eye at the eye hospital, and that is saving her sight in one eye. My father died here following a series of heart attacks. My mother was here for 7 months waiting for a placement, as you all know. And that's the motivation for me to become a governor. Being a governor here has helped me to feel close to my mum and dad. I have 2 regrets. One is I will not get a chance to serve the full 9 years, but 8's close enough. And my other regret is the reason I became a governor was to try and put an end to older people being stuck in hospital, which still hasn't occurred. But thank you to you all for the advice, support and guidance I've received from you all. I'll miss this, and I miss you all. I have a big hole to fill in my life now, but I'll try and find a use somewhere. Thank you for the last 8 years. As they say, it's been a blast.
Oh,
Only thing I have to do now.
oh, that is so sad. John, that was so powerful. And I think what spoke to me was the importance of having governors that are so very rooted in our communities and being able to speak to the trust from that place of knowledge and direct experience of what matters most, you know. So thank you. We're going to miss you too. And I'm sure we can find some way to inveigle you back into some role or other across the group. There will be opportunities because we're going to, you know, one of the things we're setting up is, I haven't talked about it today. Yeah, the Patient and Care Advisory Group to support the development of the joint clinical strategy. So that'll be drawing on some governors, but also people who use our services or have experience of them, John, from across the 2 trusts to give us a view on how we roll out the changes and development of jointly managed services.
Well, if you join the Patient and Care Experience Group at MBT, you can still take part in the non-accepted lecture interviews and focus groups.
I'm sure they'd welcome you. Yeah. Okay, and then finally, I mustn't omit to acknowledge Libby, who's done 3 years with us, but who sadly isn't here today. But we'll pass on best wishes to her as well. And Tom, I've realised why I called you David. It's because I've got a really good friend who's called David Fruin. I don't know. It's quite an unusual name, isn't it? So maybe I'll catch you. In Northumberland, but you know, not very handy. But yeah. So apologies for that. I was just getting a crossfire in my brain. Okay, everybody. I think we are all done. So many thanks indeed for being with us today and for contributing so well. Thank you. Appreciate it.
Thank you.